Good evening, everybody, and welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Baljinder Dhinsa from Kent, United Kingdom. Dr. Dhinsa is a fellowship-trained consultant orthopedic surgeon specializing in treatment of foot and ankle conditions. He currently works in Kent as well as in London in the United Kingdom. After his undergraduate degree from Guy's, King's, and St. Thomas Medical School, he completed trauma and orthopedic higher surgical training on the Southeast Thames rotation. During this training, he held the role of Academy Doctor at the Charlton Athletic Football Club, which provided him with the experience of managing sports players. To further his foot and ankle training and to learn the latest advances in techniques, he completed British Orthopedic Foot and Ankle Surgery approved fellowship at the Guy's and St. Thomas Hospital and also in Malawi. He has also taken part in a visiting fellowship with Professor Hintermann in Basel, Switzerland. If you've noticed, Dr. Dhinsa has delivered a couple of lectures on our channel and it's already reached a huge audience. And today is my great honor to bring back Dr. Baljinder Dhinsa for this wonderful live program. Over to you, Bal.
Thank you, Hitesh, and thank you for everyone that's tuning in. Once again, like I mentioned in my previous talks, I'm more than happy if you have any questions to post them to Hitesh or on the YouTube channel, and I'll try to get back to you as soon as I can. So today's talk is on lesser toe deformities, and principally I'm going to talk about the common deformities I see, which is more the hammer toe, the claw toe, and the mallet toe. Go over some of the anatomy, pathophysiology, and then treatment options. So first of all, it's the term mallet toe, hammer toe, and claw toe often gets intertwined and mixed. So I think it's important to get clear the nomenclature that we're going to use for this talk. With the mallet toe, I'm talking about the distal phalanx flexing on the intermediate phalanx. For hammer toe, I'm talking about the PIPJ flexing on the flexed, so it's the intermediate phalanx flexing on the proximal phalanx. And for claw toe, we're talking of flexion of the distal interphalangeal joint, proximal interphalangeal joint, with hyperextension of the metatarsal phalangeal joint. And these are some of the pictures that are demonstrating that a bit more clearly. So these deformities, they can be either static or dynamic. And it's important in the examination to decide on the treatment protocol to identify which one we're dealing with. And they may be associated with other forefoot, midfoot, or hindfoot abnormalities, or they may be purely isolated. Now, as I mentioned a number of times, claw toe tends to be more multiple toes, whereas hammer and mallet can occur in isolation in individual toes. They're often associated with poor footwear, and this is the most common cause. And hence, this is why you most commonly see lesser toe deformities in the shoe-wearing population. You also can see this in inherited causes, congenital neuromuscular conditions. And also, as I mentioned, poor footwear is common, and this is the reason why I think commonly women are more affected than men. But this is just a bit of what we see subjectively. There's no fact behind this. So if we start with the mallet toe, the cause of this are not fully known. I said it's often due to footwear, but it's also often idiopathic. It may be after hammer toe correction from scarring or contracture of the long flexor tendons. It could be post-traumatic. Inflammatory causes such as rheumatoid arthritis or psoriatic arthritis. And it often involves one toe being longer than the adjacent toe. And what this causes is because the toe is being squashed within the shoes, it's causing a flexion deformity. And then you get a flexible flexion deformity, which then can become a chronic, more rigid deformity. We know there's tightness of the FDL that's seen with this, but we don't know whether this is the primary cause or secondary change that's seen. And that's where we need to clarify whether it's dynamic or static to decide whether it's worthwhile releasing the flexor tendon with the treatment options. Patients often come with pain on the tip of their toe, or they may have callus formation on the dorsal aspect with pain around the distal interphalangeal joint. And if it's a very severe mallet, they may get toenail deformities, and they may get some fungal infections or ingrowing toenails as well as a result of it stubbing on the floor surface due to degree of mallet deformity. Then we go more proximal. We have the hammer toes. Once again, this is multifactorial, often put down to having poor fitting shoes as the reason for it to be occurring. And it tends to be a condition that happens due to repetitive injury and recurrence of the trauma that's occurring to the foot. And that's why we tend to see the incidence increasing with increasing age. and the peak is around the 5th to 7th decades of life. Common causes are muscular imbalance, which can be neuromuscular due to Charcot-Marie tooth, cerebral palsy, multiple sclerosis, degenerative disc disease, or compartment syndrome as some of the common causes. It may be secondary to an insensate foot due to a neuropathic, secondary to diabetes. It could be due to inflammatory arthritis, such as with the mallet toe. And it also may be associated with a hallux valgus, as you can see in this picture, where the second toe has no space to sit down because of the hallux valgus, the severity of it, and therefore the toe has to elevate. Then doing this, it causes hyperextension at the metatarsophalangeal joint, which then leads to a hammering of the toe. And then we move on to claw toe. The etiology, once again, is not completely clear. It may be associated with the same conditions as a mallet toe, Hamatos, and often as a result of a muscle imbalance between the intrinsics and intrinsics musculatures. It usually involves multiple toes, as I mentioned before, and it can be associated with a cavoid foot, and also the numerous neuromuscular conditions that are associated with that. The ones we often see in my practice are people that have possibly had CP or polio in the past. They often have a claw toe or a pes cavus, as I mentioned. Now, the patients with claw toes often come with a painful burst over the proximal interphalangeal joint due to the rigid nature. As the deformity becomes more rigid, the toe strikes the top of the shoe and causes frictional changes. As the toe box is pushing the proximal phalanx into the metatarsal head, the metatarsal head is being forced more plantarward. As the toe slowly subducts dorsally due to this pressure, the plantar fat pad is pulled distally, and the metatarsal head becomes more prominent on the plantar aspect of the foot. And often when you see patients who come to see you, it's because they're feeling the pain at the bottom of their foot. And in severe cases, they may even have ulceration. As I mentioned, etiology isn't completely clear, but it is being put down to footwear being a common problem for development of hammer and mallet toes. And as you can see with these typical footwear that you see females wear, the toes have to conform to the toe box, and this causes a buckling and a flexible flexion of the interphalangeal joints and a hyperextension of the metatarsophalangeal joint. And then this, if repetitively done, can lead to a chronic deformity. And this is what leads to the imbalance between the flexors and the extensors. So we're just going to go back over the anatomy of the foot, just so we can then, when we discuss the management, it becomes a bit more clearer. So when we look at the extensor mechanism, is really the extensor digitorum longus. As it passes over the metatarsophalangeal joint, it trifurcates, and you get a central slip which goes into the intermediate phalanx, and you have the lateral slips which go into the distal phalanx. And they're held over their metatarsophalangeal joint by an extensor sling which connects with the plantar plate on the plantar aspect. On the flexor aspect of the toe, you have the flexor digitorum brevis, which has the two slips which go into intermediate phalanx, and then you have the flexor digitorum longus, which goes into the distal phalanx. And as you can see, the axis of the rotation, the center of rotations are such that if the toe remains in neutral, the flexors will work as a flexor at the metatarsophalangeal joint, and the extensors will work as extensors at the interphalangeal joints distally and proximally. And this is how they balance each other out in a neutral position. And then the intrinsics consist of interosseous musculature as well as the lumbricals. As you can see, the interosseous tendons are located dorsal to the transverse metatarsal ligament, and the lumbricals are located plantar to this ligament. They're both plantar to the axis of motion of the metatarsophalangeal joint, and therefore they act as a flexor at the metatarsophalangeal joint, and they pass dorsal to the proximal phalangeal joint and distal phalangeal joint, and so therefore work as extensors on these joints. And this is an important process, important understanding to know for how they balance with their extrinsics. And as you can see, an interosseous provide two small slips to the extensor hood as well, whereas the lumbricals attach directly. As I mentioned, the extensor hood connects with the plantar plate, and the plantar plate is a combination of the plantar aponeurosis, the plantar capsule, and it helps to stabilize the metatarsophalangeal joint. It's a static resistance of the plantar capsule and a dynamic force of intrinsics which pull the proximal phalanx back into its neutral position during a gait. And it's during the gait where you get extension of the proximal phalanx on the metatarsal head. And it's this repetitive dorsiflexion which can cause attenuation. So it's important that the capsule, the dynamic force intrinsics, pull the proximal phalanx back into its neutral position. The metatarsophalangeal joint is also stabilized by the collateral ligaments. And the plant, as you can see here, the plantar plate inserts at the base of the proximal phalanx, but it's attached to the metatarsal head by only a thin layer of synovial tissue. And the central, the plantar plate has a role with the collaterals in stabilizing the metatarsophalangeal joint, as I mentioned. And the plantar plate also has a role in stabilizing the position of the FDL, as you know from when you do surgery for vials. We know the role of the collaterals and the plantar plate in this, especially when you have a plantar plate rupture. The collateral ligaments, which I mentioned, consist of the collateral ligament, phalangeal collateral ligament, and accessory collateral ligament, and these insert into the plantar plate and provide further stability. The transverse metatarsal ligament attaches to the adjacent medial and lateral borders of the plantar plate, and they provide further stability within the intermetatarsal space, as well as to the plantar plates. So going back to what I mentioned about the role of the collaterals are the primary stabilizers of the lesser metatarsophalangeal joints. And as I mentioned about the rotation, the position of the proximal phalanx at the metatarsophalangeal joint is subject to the actions of extensor digitorum longus through its sling mechanism. And this works in opposition to the weak antagonistic intrinsic muscles, as well as the static capsule and plantar plate. So it's an intricate balancing act between the extrinsics and intrinsics, as well as the collateral supporting structures and the plantar plate. The position of the interphalangeal joint and intermediate phalangeal joint and distal phalangeal are subject to forces of the long and short flexors, and these are opposed by the weak intrinsic muscles. And so therefore, in summary, the metatarsal phalangeal joint is affected by EDL, as well as the antagonistic weak intrinsic muscles, and the interphalangeal joints, intermediate and distal, are subject to the forces of the long flexors and long and short flexors, and opposed by the weak intrinsics. It's important to understand this reasoning why the joints work in different ways. And you can see why a mix match of these extrinsics overpowering intrinsics can occur at each joint and have different outcomes. We have flexion at one and extension at the other. So, as I mentioned, the EDL helps to extend the interphalangeal joints at the of the proximal phalanx. Sorry, let me repeat that. The extensor digitorum longus helps to extend the interphalangeal joints of the distal and proximal if the proximal phalanx remains in neutral position, is not hyperextended. The flexor digitorum longus helps to flex the metatarsal phalangeal joint if the proximal phalanx is in neutral and is not hyperextended. So therefore, the metatarsal phalangeal joint is the key stabilizer and is important in the process of claw, hammer, and mallet toes. So you can see from the importance of the metatarsal phalangeal joint, if the metatarsal phalangeal joint is chronically hyperextended by having a tight shoe box or having high heels or tight fitting shoes, as we saw in the previous pictures, the plantar structures gradually become stretched and inefficient. And then the EDL loses its tenodecing effect on the interphalangeal joints, and these joints tend to migrate into flexion. As the proximal phalanx extends and goes into hyperextension even more, the extrinsic flexors are under greater tension, and further increasing the flexure deformity at the proximal interphalangeal joint and overpowering the intrinsics. So it has a powerful effect on the whole toe. And this is all based and hinged on the metatarsal phalangeal joint, and this is a key understanding. So going back to now we understand anatomy and the pathophysiology, let's talk about assessment. As with all foot and ankle conditions, it's important to assess from the top down. You need to assess the back to see for any neuromuscular sequelae, marks, or suspicion of causing any neuromuscular past medical history. You need to do a full neurovascular examination, and then you need to go to the standard orthopedic look, feel, move. So when you're looking for scars, looking for hairy patches, you're looking at the alignment of the foot. Is it a cavoid foot? Is it a flat foot? Looking for plantar callosities on the sole of the foot, looking for any ulcerations. And also looking to, as I mentioned with hallux valgus, seeing if there's space for the lesser toes to sit down or if they're being squashed by the other toes, and that's why they're elevating. When you're feeling, you're looking for tenderness, you're looking for swelling, you're looking for inflammation of the tendons, range of motion of the ankle joint, as well as the metatarsophalangeal joints and interphalangeal joints. And when we're looking at more proximally, when I talk about ankle joint, we're particularly looking at the calf musculature. So you do Silverskjold's test to see if there's any forefoot overload secondary to tight gastrocnemius or tight Achilles tendon. And this can then lead to forefoot overload, which can then lead to the sequela of developing hammering of the toes. It's also important to check the stability of the interphalangeal joints. So doing a mini Lachman's, as demonstrated in this picture at the bottom, is important to suggest to see if there's stability of the stability of the metatarsophalangeal joint, to see if there's any rupture of the plantar plate, and this may cause to subluxation and then causing some hammering and also clawing. It's important of the interphalangeal joints to check whether it's a fixed deformity or rigid deformity, and this is just gentle range of motion to see if it will correct. It's also important when you dorsiflex and the plantarflex ankle to see if the deformity improves. And once you've done this, you look at imaging. The imaging I tend to get is an X-ray weight-bearing view, AP and lateral, as well as a medial oblique. I'm looking at this to look at the joint surfaces, as well as to see if there's any elongated lesser metatarsals or a short first metatarsal, which leads to subjective elongated lesser metatarsal. And if you're suspicious of a mortise neuroma from the metatarsalgia, you can also get an ultrasound plus or minus injection to as a first line of treatment. If you're worried about a plantar plate rupture, I would certainly look at getting an MRI scan to delineate this a bit further. As with all things, it's important to exhaust non-operative measures first, as you want to avoid the risk of surgery as much as possible. And simple things are important: wider fitting shoes, having toe spacers, using lesser toe hoods to try and bring the toes down to correct the hammering, using a stiff soled shoe to try and support the foot. And the key things are adjusting your footwear, not just during the treatment, but long term. So if you're used to wearing high heels, tight fitting shoes, wearing bigger shoes, being more supportive to prevent friction and ulceration. And these are very important steps to try. Not everyone wants to do this, but you have to explain the need to try this to alleviate the initial symptoms. And if it resolves it, then they've avoided surgery. If you've exhausted all these options and the patients are still suffering, then you need to move on to the surgical options. But I think a good period of 6 months of non-operative measures is required before you go towards surgical options. But obviously with this, patient compliance is important, especially if someone wants to get into fashionable high heels or narrow toe boxes, then it becomes a bit more difficult to judge how compliant they're being. Now we mentioned options of non-operative measures, and I mentioned orthotics here again. And it's always important to try an orthotic to see if this alleviates symptoms. As I said, this can be a simple, if there's associated with a midfoot deformity, such as a flat foot, a simple arch support. It could be a sling to separate the toes, support the toes, avoiding ulcerations. However, it's important, once again, as I said, an examination to determine whether it's a flexible or rigid deformity, and this will determine what you do with regards to treatment. Now, for the mallet toe, which tends to be isolated at the distal interphalangeal joint, the question is it flexible or rigid? This will determine whether, if it's flexible, you can certainly consider doing an FDL tenotomy under either local anaesthetic or a general anaesthetic, and this will potentially allow the toe to correct. If on X-rays and imaging there's shown to be some degenerative changes within the distal interphalangeal joint, you may want to combine this with a condylectomy just to improve the correction and ensure it doesn't reoccur. And certainly if you do this, I tend to hold the joint with a KY at the same time. If the deformity tends to be more rigid, I think the option is really only, if you're going for surgical options, is an arthrodesis. And the arthrodesis is performed with under general anaesthetic or a regional block. And it's an elliptical incision over the distal interphalangeal joint. You release the extensor tendon. You release the collaterals either side of the joint, protecting the digital neurovascular bundles. And then you prepare the joint surfaces. I tend to use a nibbler, and I remove the cartilage and shorten at the distal aspect of the interphalangeal joint, the base of the distal interphalangeal joint. And once the cartilage is completely removed, I then reduce the joint and hold this with a 1.6 millimeter K wire. This K wire is bent and cut at the tip, and they stay with this for 5 to 6 weeks, and I'll then remove the K wire in clinic. When we get X-rays after removal of the K wire, you don't often see a bony fusion, and often it's a fibrous fusion. However, the toe remains straight, is in a saturated position, and it often will continue to remain like that. So I don't get too upset if I don't see a full bony union at 6 weeks. If we go to more proximity to the hamato, once again, it very much determines whether it's a flexible and a rigid deformity. And also you can get a complex hamato and a simple hamato. In this section, I'm going to talk about the simple hamatos. The complex hamatos is when you get some extension of the poxophalanx and the metatarsal phalangeal joint, but I'll include this aspect of it in the claw-toe discussion. So for the simple hamato, if it's flexible in nature, options can be a soft tissue procedure, such as a Gurdstone-Taylor type procedure. And with this, you make under once again regional block or a general anaesthetic. I always use a tourniquet just because I feel it helps me visualize things. You make a plantar incision on the toe. You identify FDL towards its insertion in the distal phalanx, and then you remove it from the distal phalanx and split it into two. You then make a dorsal incision over the intermediate phalanx, and you bring the splits either side medial and laterally over the intermediate phalanx and tie them together. You can combine this with a condylectomy if you wish as well, but this often brings the toe down and allows it to correct the flexible deformity. Certainly I'd protect this in a reverse heel type shoe or flat surgical shoe for at least 4 weeks. I review the wound at 2 weeks to ensure the wound's healed nicely. This procedure has been associated with a risk of reoccurrence, and it can also lead to extension deformity at the distal interphalangeal joint as well. So these are just things you need to be wary of, but it is a good procedure and you generally have good outcomes from it. If it's more rigid in nature and the metatarsal phalangeal joint is stable, as in there's no deformity associated with this, then certainly we're looking at an arthrodesis type procedure. You may need to, once you've done arthrodesis, if the toe is still extending a little bit, you may need to augment this with a extensor tendon lengthening, which I tend to do with a Z lengthening. The key thing when you do this is that you need to ensure there's enough space for the toe to sit down. So there's no point doing a PRPJ fusion of the second toe, for example, if there's a hallux valgus and the second toe, despite you fusing it, is going to be elevated because there's no space for it to sit down. So you may need to combine this with surgery to the hallux to ensure there's space. So this is just a demonstration of the Girdlestone-Taylor type procedure. And you can see here where you detach the FDL from the distal phalanx and you bring it up over the intermediate phalanx. You can bring it up into over the proximal phalanx as well, and you stitch it together. They often try to say if you're going to do it into the over the proximal phalanx, it should be over the extensor hood as well. And just some examples of the proximal interphalangeal joint arthrodesis. Now, there's been many options described how to do this. As I mentioned with the distal interphalangeal joint, I tend to use a K-wire. Pardon me. For the proximal interphalangeal joint, I also tend to use a 1.6 millimeter K-wire to hold it in situ. But there have been people that have used screws for this. There are people that have used implants, intramedullary implants. Some have been metal, some have been plastic. There's been multiple variations of the same technique. Certainly, Complications are often associated with this have been with swelling, and with the K-wire certainly is a risk of infection because you have a wire with an entry point into the bone, which can lead to the risk of osteomyelitis as well. The evidence for this is quite low, but obviously there is a risk and there is a percentage that get this, and so therefore there has been a drive intramedullary devices. However, it depends which one you use. I have used an implant called Starfuse, which is made of manganese, and this is a metal which will slowly absorb and disappear. But we're still in the early stages of using it, so I don't have any outcomes beyond 6 months at the moment. But the early results have been good with regards to X-ray signs of fusion. However, with all these implants, like I said, still have the risk of swelling, and it depends how easy the implant is to use. I tend not to use screws because I find the screw heads cause a lot of prominence on the tip of the toe, and I also find that it's a permanent implant. And I certainly would rather use an implant that I either remove, such as a K-wire, or an absorbable implant. And now we move on to Clato. It's important to examine the patient and to determine which way you're going to go in regards to management of this. If there's a pes cavus present, it's important to deal with the midfoot and hindfoot deformities initially. This will often settle the clawing. If there's dynamic clawing without a pes cavus, you concentrate on the forefoot. And if there's no clawing when the ankle is plantar flexed, it's certainly a flexible deformity, and then you can manage it with the soft tissue type procedures and joint preserving. So if they are flexible and it's more forefoot related, not related to hindfoot or midfoot, certainly a bit like the Hamatos, you use options such as Godson Taylor, and you may augment this with an EDL lengthening as well to try and get the toe to sit down. If it's more rigid in nature, certainly you start more proximal and then move distally with regards to the deformity. So as I said, it all hinges on the metatarsophalangeal joint. So you should do a metatarsophalangeal joint capsular release and try and get this joint to sit down into neutral. You then can consider extensor digitorum longus lengthening to try and once again to get the hyperextension of the proximal phalanx to reduce and get to neutral. If this doesn't correct the deformity, then you can add in a Weil's distal metatarsal shortening osteotomy, which you can see in the picture here. And you tend to you've exposed the metatarsal head already in the first part of the procedure, and you tend to make an oblique cut, which is I try to make parallel to the fifth metatarsal, and you just shorten the metatarsal head this way. And I find once you release the collaterals and you've completed the cut, the head tends to shorten to the position it wants to go into naturally. And then I tend to fix this with a screw, such as a snap-off screw, which is you drill directly into the bone, and there's a very little prominence from this. And then you resect the dorsal excess bone that's left behind. If once again after this is still a deformity, you can augment this with a proximal interphalangeal joint arthrodesis type procedure, and then hopefully you should get a satisfactory outcome. Once again, it's important to identify the right procedure for the right patient. Otherwise, it can lead to further deformities and pressures elsewhere. And it's important that you offload the correct areas and you treat the correct areas to ensure the balance is corrected with regards to intrinsics versus extrinsics. Complications associated with all these procedures include swelling, reoccurrence, vascular compromise, particularly if it's in a diabetic patient, but more so when you're doing proximal interphalangeal surgery, you are releasing the collaterals and you're at risk of injuring the digital vessels, and therefore it's important to assess the foot after the tourniquet is down, once the dressing is on, to ensure capillary refill is returned. With the Weil's type procedures, you really need to be careful of elevation at the metatarsophalangeal joint, which can occur, and certainly patients can complain of a floating toe. So where you've shortened the metatarsal, the extensor tendon becomes slightly less tensioned, and the toe can feel like it's lacking control due to the detensioning of the tendon. There's obviously associated risk of infection, particularly if you're operating multiple places in the same foot, and also if you're using K-wires. And there's stiffness that can occur particularly I found with the valsostomy, with the intermetatarsal approach, they do get a lot of scarring, which can lead to stiffness, and this once again can lead to elevation of the poxophalanx, extension of poxophalanx compared to the metatarsal head. And so I'm quite keen to start manipulating the lesser toes following a vals at about week 3 to 4 to try and reduce this scarring. As we mentioned, you can get scarring on the flexor tendons as well from other procedures, which can then lead to stiffness and lead to hammering of the toes as well. So you need to be careful of this. I haven't mentioned other conditions such as plantar plate ruptures, because I don't see them as often, but certainly if you do see a plantar plate rupture, and this is confirmed on MRI scan, the first line of treatment is with Weil's osteotomy. Then it's through that osteotomy that you can repair the plantar plate, and you can use that with several implants, which you can either stitch plantar plate directly, or you can repair the plantar plate and then using devices pass it through the poxophalanx to tighten up the plantar plate. And certainly that constitutes sometimes part of the surgery, but it's not in my patient cohort. I don't see this that often. Thank you. I know that was a bit of a run through. It's actually the actual options of surgical management are quite easy to delineate once you identify which pathway you're going to go along. But it's often the diagnosis and getting the right diagnosis is difficult, and that's important. It's important to combine trying to deal with the underlying problem, but also dealing with the symptoms. And if a patient, for example, has a hammering toe and they got pain from the dorsal friction and pain from the shoebox, this is what you should deal with, and you shouldn't have to necessarily deal with all the hindfoot, midfoot deformity straight away if it's a simple hammering. But obviously, if it's a claw toe with a cavoid foot, you then do have to deal with that. So it's important to address the treatment options for the particular patients and customize it. Thank you.
Thank you, Bal, for yet another brilliant talk from your side and very clear. Just a couple of questions, just to make it very clear to the residents, because what happens very commonly is these three conditions that you mentioned, hammer, mallet, and claw, are easily confused.
Yes.
Okay, so when you talk about the claw, our primary pathology is at the MTP joint, right? It is a hyperextension of the MTP and the flexion of the other joints. And when you talk about the hammer, it is at the PIP.
Well, I think you have to be very careful with a hammer. It can be at the MTPJ as well. So it's
where is the primary? MTP is compensatory, right? So the primary is at the PIP, isn't it?
Yeah. Primary is at the PIP, but the MTPJ can be compensatory, and so you sometimes have to deal with the MTPJ as well. And so, particularly, I often see people with hammering toe, and they have plantar callosities under the metatarsal heads, and that is secondary. But when you get X-rays, they have an incidental finding of elongated metatarsals. So you wonder whether the forefoot overload with the elongated metatarsals has led to the hammering. So with those patients, they're what we call the complex hammer toe. And I sort of in this talk, I treated them as a claw toe. So with those complex ones, I would deal with the metatarsal elongation with a Weil's osteotomy and then deal with the PIPJ as well. But with the simple PIPJ hammering, I'll just deal with the PIPJ.
Okay. Thank you, Bal. So we can see all these three deformities, we can classify them as rigid and flexible. Yeah. And that way, I mean, it's very difficult to remember it otherwise. And if it is a flexible one, we can use shoe wear or footwear modification. And otherwise, we can do a tenotomy, right?
Exactly, yeah. But certainly, I wouldn't do so much do tenotomy. I'll do a tendon transfer.
For the claw and hammer.
For the claw hammer, yeah. For a mallet, you can't. It's a tenotomy, yeah.
Okay. So for the claw and hammer, if you have a flexible deformity, you would do a Girdleston-Taylor flexor to extensor transfer, isn't it?
Yeah, exactly.
Okay. And if it is rigid for the claw and hammer, we need to do bony procedure, isn't it? So for the
Yeah,
claw, you need to do some form of MTP joint stabilization. Am I right?
yeah. So for the claw, if it's with the claw, if it's flexible, sometimes I still do a valsostomy to shorten it because the deformity is at the metatarsophalangeal joint. If it's rigid, you almost certainly have to do a valves all the time, and then you do a fusion at the proximal interphalangeal joint to straighten it. And the key thing is, as I mentioned, is to try and get the proximal phalanx to be neutral to the metatarsal head. And that's the key thing. Is the problem is when it's extending, it causes instability on the metatarsal head.
Thank you, Bal, for that. And what the other entity that we commonly come across is called the crossover toe, isn't it? So
Yes.
it's something that you have in hallux valgus where the first toe crosses over to the second, isn't it? Is that the
Yeah.
classic situation?
Yeah. And that's a challenge to deal with because even if you create space for the hallux valgus to correct the hallux valgus and get the second toe to sit down, if you do, even if you do vials, you do a PIPJ fusion, there's a soft tissues the difficult thing because the toes can still turn either way. So for those ones, you have to be very careful and delineate whether, when you examine them, that when you correct the hallux valgus, will the second toe have space to sit down and will the tissue allow it? I think sometimes, especially in the elderly patients and the ones that don't want big surgery, so when the hallux valgus is associated with some arthritis, you think about fusing the hallux MTPJ, I would certainly suggest doing an amputation of the second toe to avoid any major surgery, and that often resolves their symptoms.
Thank you, Bal. I think that's all the questions that we have for this session, Bal. It is a very clear lecture, and I'm sure this is going to benefit a lot of people all over the world. Thank you so much again, Bal, for coming in.